Hello everyone. Today I'll be talking about management of atrial fibrillation. I will be mainly touching upon the clinical presentation and a brief management of atrial fibrillation. And in the video, I will mention atrial fibrillation as AF from now on. So starting with the ECG that we see in a patient with AF, we first of all see an irregular rhythm, as you can see in this picture. The RR intervals are not constant, so that's irregularly regular. The atrial rate is increased to around 300 to 500 per minute, and the ventricular rate may be high or it may be normal. Now that does depend on the type of patient. For example, young patients have a healthy and a faster AV nodal conduction velocity, and therefore they tend to have a rapid ventricular rate, whereas older patients have slower AV nodal conduction velocity, so they have a slower heart rate because all the impulses from the atrium are not conducted to the ventricles because of the slow AV node velocity. Also, there are no P waves. Again, as you can see in this picture, you just get a fibrillatory baseline. This is like a very irregular fibrillatory baseline, and there is no proper P wave in this ECG. So there are various types of atrial fibrillation. There is paroxysmal, which terminates spontaneously within 7 days. So the cutoff here is 7 days. Persistent AF does not terminate within 7 days. It lasts even longer than that. And usually we require pharmacologic therapy or cardioversion to treat that. The third is a long-standing atrial fibrillation that lasts for more than 12 months. And finally, there's permanent AF, wherein there is a joint decision made between the patient and the doctor to not really pursue a rhythm control strategy of treatment, and the patient is usually not bothered much by the symptoms of atrial fibrillation. Next, I talk about the presentation. So mostly the patients may be asymptomatic, or they may present with features like palpitations, weakness, dizziness, and lightheadedness. But also, more severe presentations can include dyspnea, angina, pre-syncope, and sometimes AF can also present with an embolic stroke because of thrombus formation in the atrium. And it can also present as a tachycardia induced cardiomyopathy with features of heart failure like dyspnea, orthopnea, and peripheral edema. Now, for atrial fibrillation, there are certain risk factors that lead to long-term atrial remodeling that then creates an underlying substrate on which atrial fibrillation will be precipitated by certain triggers. So you have two things here, you have two terms. One is risk factors and one term is trigger. So risk factors are what predisposes the individual to atrial fibrillation by creating that favorable substrate. Those include hypertension, advanced age, mitral valve abnormalities that lead to an enlarged left atrium, LV failure, coronary artery disease, obesity, diabetes, smoking, and COPD. So these cause atrial remodeling and create a favorable substrate for atrial fibrillation. Now, there are certain triggers that which can start off in atrial fibrillation when they act on an atrium which already has a favorable underlying substrate. Now, these triggers are things like hyperthyroidism, binge drinking, any cause of increased sympathetic activity like illness, surgery, drugs like cocaine, beta agonists. All of these are triggers that on acting on an atrium that has been remodeled because of risk factors will create an atrial fibrillation. Now, AF can also happen in healthy people who don't have an underlying substrate, and in those cases we just have to remove that trigger and the further risk of recurrent atrial fibrillation will be low. But that is not the case with someone who also has risk factors like what I mentioned here, because in patients who have risk factors, the risk for a recurrence of atrial fibrillation is quite high. Now, coming to a very important score, that's the CHADS-VAS score. This is basically a risk stratification scheme to determine the 1 year risk for thromboembolic event like a stroke in a person who's not anticoagulated. Now this criteria, so I'll just spell out the criteria. So C is congestive heart failure, that gets 1 point. H stands for hypertension, 1 point. A2 is an age that's more than 75 years, gets 2 points. Diabetes gets 1. History of stroke or transient ischemic attack gets a score of 2. A vascular disease like prior myocardial infarction gets a point of 1. Age 65 to 74 years gets 1. And SC stands for sex category female, gets a point of 1. So the total score comes out to about 9. And how do you interpret the score? So for a total score of 0, the risk for stroke is low, and we don't generally put them on a long-term anticoagulant. But if the score is 1, that would be a moderate risk for stroke, in which case you can decide whether to give an oral anticoagulant or not. But if the score is 2 and above, that means the risk for stroke is high. And in those patients, we have to start them on oral anticoagulants like warfarin or the oral agents like apixaban, rivaroxaban, and dabigatran. And now we actually prefer the novel oral anticoagulants over warfarin. Now coming to the evaluation in a patient who presents with atrial fibrillation. So first off, we take their history and physical examination. We take their ECG to confirm the diagnosis and also to check for any signs of ischemia. We have to rule out any underlying myocardial infarction or any myocardial ischemia for that matter. Then that is also to check for any risk factors for the atrial fibrillation. Then we go for blood tests like your CBCs, electrolytes, and renal function tests. In fact, getting a renal function test is very important because that helps us decide the type of anticoagulant to be used, because certain anticoagulants cannot be used in patients with renal insufficiency, for example. Then we take a transthoracic echo, that is to look for any ischemia, any valvular abnormalities that would have acted as a risk factor for atrial fibrillation, to check for any LA dilatation or any cardiomyopathy, because all of these factors are risk factors for AF. Then very important, we do a thyroid function test. So we get a TSH level and a T3, T4 level, because what happens is in hyperthyroidism, the high levels of the thyroid hormones will increase the sympathetic action on beta-1 receptors of the heart. And this can present as AF that acts as a trigger for atrial fibrillation. In fact, in a person with hyperthyroidism, AF may be the only manifestation also. So that's very important to check the TSH levels. And finally, we have to identify certain triggers or risk factors so that we can stop those triggers and manage the risk factors correctly. Now, a few questions that have to be addressed regarding treatment is, the first is, does the patient need immediate cardioversion? I will be telling you soon in the next slide about who to be immediately cardioverted. The second is, should the drugs for AF be given IV or through the oral route? That basically depends on how severe the patient is or if the patient is stable or not. And then after the initial management, do we go for a long-term rate control strategy or do we go for rhythm control strategy? So these are three important questions to look at. Now, approach to patients with new onset AF. First, who should be receiving urgent cardioversion? Just remember, anyone who is hemodynamically unstable must receive urgent cardioversion to convert the rhythm into sinus rhythm. Also, people who have myocardial ischemia, like they have chest pain, they have heart failure manifestations like breathlessness due to pulmonary edema, for example, and patients, as I've mentioned, who are unstable with hypotension and shock, these patients need to receive urgent cardioversion. So coming to the general management options that we have to treat atrial fibrillation, you have two options. So one is controlling the rhythm, the other is controlling the rate. Rhythm control usually involves cardioversion, either electric or pharmacologic. I'll be talking about that soon. That will be followed by maintenance of sinus rhythm with antiarrhythmic drugs. That comes under rhythm control. Rate control essentially is controlling the ventricular rate. And very briefly, you can divide the management into three categories: patients who need emergent management, meaning those who are hemodynamically unstable; urgent management, people who are symptomatic but they are stable; and elective management are just for asymptomatic patients. Emergent management includes immediate cardioversion, as I mentioned. Urgent management would be to give an initial IV rate control agent to control the ventricular rate. That will be followed either by an elective cardioversion, or you can go for long term control either with a rate control strategy or a rhythm control strategy. Whereas for an elective management, we just put them on oral drugs like, again, it could either be rate control strategy or rhythm control strategy. So the details of all this will be dealt with in the next few slides. Starting off with rate control. So the aim of rate control strategy is to control the ventricular rate if it is elevated, and by that I mean more than 100 beats per minute. So what happens is, we know the atrial rate usually goes up to 400 per minute because in fibrillation, many foci in the atria are just giving out impulses in a very irregular fashion. So the atrial rate is really high, like 400. But due to the slower AV nodal conduction velocity and a conduction delay that happens at the AV node, all the impulses from the atria don't really get conducted to the ventricles, and so the ventricular rate will usually be between 90 to 170 per minute. But you can encounter cases, that is people with AF but a slow ventricular response, like a rate less than 60. In those cases, you should start thinking about any cause that could slow down AV nodal conduction quite a lot, like a very high vagal tone, or if the patient is on drugs like digoxin, because digoxin slows the AV nodal conduction velocity. On the other hand, the ventricular rate can be extremely high, like more than 200 per minute also. Those cases can happen in patients with hyperthyroidism or any cause of catecholamine excess. So when we look at the rate, you have to think of all of these possibilities. Next is, why do we go for rate control? Why should we control the ventricular rate? First is that it prevents hemodynamic instability. So when you control the ventricular rate, you are making all the ventricular contractions more effective, and this allows effective pumping of blood, and this prevents instability. Second, it prevents tachycardia mediated cardiomyopathy. That's very, very important. And third, you are actually there is a possibility of spontaneous cardioversion in the first 48 hours. So you are keeping the patient's rate controlled and stable, so that you're waiting to see if that spontaneous cardioversion can happen or not. So the goal of rate control is to bring the heart rate to less than 80 per minute. And we should not really start a rate control agent if the heart rate is already less than 80. The agents we use are beta blockers, calcium channel blockers. Now this is important. Rate control always precedes a rhythm control strategy. So any decision regarding cardioversion or any further rhythm control strategy in stable patients must only be done after the rate has been controlled first. So initially, the patients are acutely managed with rate control if their ventricular rate is high, and only then we decide only then do we decide whether we need a rate control or a rhythm control as a long-term strategy. Another very important point, always have caution in if the patient has WPW syndrome, because rate control has to be very carefully selected in those patients because they have an accessory conduction pathway. In these patients, we should not use agents that can slow down the AV nodal conduction, because that will just increase the transmission of impulses through the accessory pathway. So we should not use beta blockers, calcium channel blockers, or drugs like amiodarone in a patient with these accessory conduction pathways. And these patients are usually treated with procainamide. That's the agent of choice. Now, the agents that we use for rate control, as I've mentioned before, are beta blockers. They reduce the heart rate and the AV nodal conduction velocity by acting on the beta 1 receptors. They blunt the sympathetic surge, which acts as a trigger for AF. And beta blockers are also beneficial in patients who also have heart failure. The next agent are the calcium channel blockers, which reduce the AV nodal conduction velocity. And finally, digoxin can be considered if the beta blockers and CCBs don't work, but they are definitely not the first line agents of choice. So that was with the rate control agents. Coming to rhythm control. Now, rhythm control can be divided into acute control and chronic control. For agents used for acute rhythm control, we have electrical cardioversion and pharmacologic cardioversion. Electric cardioversion is done with DC synchronized shock. Please note this is synchronized. It is important to synchronize the shock with the QRS complex to avoid precipitation of a ventricular fibrillation. Alright, and the pharmacology cardioversion options are IV antiarrhythmic drugs. They belong to class 1 agents like flecainide and propafenone, and class 3 agents like amiodarone and ibutylide. For chronic rhythm control strategy, we usually go for this if the AF is not controlled with a rate control strategy itself. And again, here we use antiarrhythmic drugs like the class 1 and class 3 agents. But here it's important to know that class 1 agents are contraindicated in patients with structural heart diseases like coronary artery disease, LV dysfunction, LV hypertrophy, because these patients they do have a high risk of arrhythmias when they are put on these antiarrhythmic drugs. So that is important to note. And finally, another option is catheter ablation, like pulmonary vein isolation, because it is seen that atrial fibrillation actually originates at the pulmonary vein ostia. So when we ablate the pulmonary veins, then that is a potential therapy for atrial fibrillation. Now, how do we choose between whether we go for rate control or rhythm control strategy? First of all, the preference for the rate and rhythm control has to be done after the ventricular rate has been controlled first. Then the patient has been made stable, and then we will decide about the long term, whether it's rate control or rhythm control. Now, the preferences that we have. Rate control can be preferred if the patient is asymptomatic with a long-standing or recurrent AF that has been going for quite some time, and also in elderly patients. Now, this is because elderly patients are prone to adverse effects from antiarrhythmic drugs, and also usually elderly patients have AF that is asymptomatic and long-standing, so we go for rate control. The cases where rhythm control is preferred are patients with a high cardiovascular risk like prior stroke or TIA, diabetes, hypertension, coronary artery disease, CKD, patients who have failed on rate control strategy, and young patients. So these are the people who we prefer a rhythm control strategy for. Now, certain principles of cardioversion in stable patients that I'd like to mention is that cardioversion, first of all, it restores sinus rhythm. And cardioversion is considered for stable patients once you have already controlled their ventricular rate if it was high. It should be done within 48 hours from the onset of AF. This is very important because the risk for thrombus formation and thromboembolism is very high very high after 48 hours from the onset of AF. So, and also the time during cardioversion is actually a time of a high risk for thromboembolism. So you have to make sure that cardioversion is done within the first 48 hours. And if the duration is more than 48 hours, it requires anticoagulation for 3 weeks before cardioversion, or you have to do a transesophageal echo at that time, and if that echo shows no LA thrombus, only then can you go for cardioversion. Also, most new onset AF usually converts spontaneously into sinus rhythm within the first 24 to 48 hours, which is why most of the time what we do is we monitor the patient for 24 hours after the onset, see if spontaneous cardioversion occurs, and only if that does not happen, then we will consider cardioversion. Now, we have to consider two important things before we cardiovert the patient. As I've mentioned, control the ventricular rate and also anticoagulate. Before cardioversion, the patient has to be anticoagulated, and even after cardioversion, we have to anticoagulate them. There are two types of cardioversion, electric and pharmacologic. And electric cardioversion is usually preferred for the first episode of AF, especially in younger patients. For patients in whom it is not the first episode, we can pick either electric or pharmacologic cardioversion depending on the patient characteristics. Actually, the advantage with electric cardioversion is that we can avoid all those drug toxicities and the need for telemetric monitoring that we have to do when we're using a drug, because drugs are definitely proarrhythmic. On the other hand, pharmacologic cardioversion can be preferred if you want to avoid sedating the patient, because electric cardioversion definitely requires that the patient be sedated. Then after cardioversion, anticoagulation must be considered for 4 weeks. It should be continued for 4 weeks after cardioversion. Now this is a chart on how to approach new onset atrial fibrillation. Starting with this portion, the right hand portion, if we are planning on cardioversion, we check if the duration of the AF is less than or more than 48 hours. If it is less than 48 hours, then the risk for thromboembolism is relatively low, in which case we will first determine the CHA2DS2-VASc score and divide those patients into either low risk or moderate to high risk. For both these patients, we anticoagulate before cardioversion, and after cardioversion, if it is low risk, we can discontinue the anticoagulation after cardioversion. No need to continue it. Although here there are a few people who would continue the anticoagulation and some who would discontinue it. So that depends on the physician's preference. And for moderate to high risk patients, we definitely, for all of them, continue the anticoagulants for 4 weeks after cardioversion. Now suppose the duration of AF was more than 48 hours. It was not less than 48 hours. There we check if the patient is unstable. If they are, then definitely immediate cardioversion. But if they're not unstable, what we do is we anticoagulate for 3 weeks followed by cardioversion. Or the other option is, at that time itself, you'll do a transesophageal echo. If the echo shows no atrial thrombus, then we can go ahead and cardiovert them. So this is the right hand side of this chart. Now, suppose we don't plan for cardioversion. This is a patient whom we are not doing cardioversion. You have to check whether the AF is valvular or not valvular. If it is a valvular AF, then go ahead and directly put them on warfarin. That's very important. If it's a non-valvular AF, then we have to check the CHA2DS2-VASc score, and depending on the score, we will give the treatment. Like if it's 0, no requirement for anticoagulation. If it is 1 or 2, we can consider oral anticoagulants like the novel oral anticoagulant agents like apixaban, rivaroxaban, or warfarin, although NOACs are preferred. If it is 3, 4, that's very high risk for thromboembolism, then it definitely requires oral anticoagulation, again with either NOACs or warfarin. So this is a general approach to the management of new onset AF. Now, final slide, I want to talk about the anticoagulation involved with atrial fibrillation. This is mainly to reduce the risk of embolization. Now, it is seen that the risk for embolization is high during and after conversion into sinus rhythm, be it either cardioversion like electric cardioversion, be it with drugs, or even if it's spontaneous conversion into sinus rhythm. there is a high risk for embolization during and after this conversion. And most of these events occur within the first 10 days after reverting into sinus rhythm. And this is especially so for patients who are cardioverted after 48 hours after the onset of AF. So, to reduce this risk of embolization is why we anticoagulate. And as I've already mentioned, chronic anticoagulation is considered based on the CHAD-SWAS score. And I'm just putting this picture here just to remind you of how we interpret the score and how we treat accordingly. And just to mention here that direct oral anticoagulants like apixaban, rivaroxaban, dabigatran are what we prefer now over warfarin, except of course if the AF is a valvular AF, then definitely warfarin is the drug of choice. So that is with our video on management of atrial fibrillation. Thank you, and I hope you enjoyed the video.